We will now ask Capucine Morelot from the PT Salpêtrière here in Paris to present to us on a very difficult and I think increasingly difficult in importance and frequent topic, and that is on the common problem of dyspnea.
Thank you. Thank you. I'm going to make my presentation in French. I'd like to thank the scientific committee for inviting me here to tell you about dyspnea, which is a very frequent symptom. I'm not an oncologist, but I'm a pneumologist. Please forgive me, the slides are in French. I didn't get it right when informed. And I'm going to speak to you about neurology and respiratory issues. This is going to enable us to understand the future treatments that are available to treat dyspnea, which is a frequent symptom for cancer patients. So here is the support or the links I got. Now, the definition, it is a subjective experience of respiratory discomfort. This is the definition that the American Thoracic Society went for, and in 2012, a new statement insisted on the subjective side of things. And this is a problem for non-communicating patients. There's the need for air that is underpinned by distinct mechanisms. It is multidimensional, the same as for pain. If you want to speak about dyspnea, you have to have some negative sensation. First, the perception, that's the sensory dimension, and what we call the affect, that's the unpleasantness with anxiety, depression, fear, and the intensity of these compounds can change. And there's also the diffusion of the symptom with an impact onto the quality of life of patients. We speaking of refractory dyspnea when there is some chronicity, and when it can happen when the patient is at rest or is making a slight effort, which can be distinguished from residual dyspnea, which can be perceived whatever the underlying pathology. Why do doctors pay so much attention to it? It's extremely frequent. That's why when you get patients at the A&E, 50% of them do have dyspnea. Some have to be vented by the resuscitation services. And it is much more rarely dealt with than pain, and it is also a morbidity and even a mortality factor and a major handicap. What about relevance to cancer? When we have a look at palliative care, the frequency of dyspnea is such that the cancers that mostly trigger dyspnea is neck and head cancer, but mostly bronchial, of course, cancers, and pulmonary metastasis. We see the percentage of patients mentioning dyspnea. Here you see the head and neck and bronchial cancer patients, so mostly those who complain from dyspnea, and brain pathologies are less and not that often triggering dyspnea. But you see that in the second column we see a modification. So in bronchial cancer, it's extremely frequent and extremely invalidating, extremely disabling, we see here more than 40% of patients, that's ambulatory patients, outpatients, who complain from moderate dyspnea or severe dyspnea. Now, the physiopathological model, which is going to enable us to identify the therapeutics we can turn to deal with the symptoms. You know that there's two geared common order box, that gives order to the rest of the brain, the somatostatic cortex, and then you're going to have a fair copy of the order given. That's what we call the corollary discharge, and this comes from the cerebral trunk. And there's going to be a comparison between the order and the way the respiratory system did respond to this common. And then there's the reaction at cortex level, and especially at the level of insula. If there's a balance between order and response, so we are in a dyspnea situation. If there's a disbalance, this is going to increase the venting response. We're going to have neurovegetative signs. That's when dyspnea appears with verbal or non-verbal language from this dyspnea, and the appearance of side reactions. Now, for the physiopathologic model, we have again this corollary discharge. We have the appearance of dyspnea. We have the sensory dimension, the affective dimension, with the emotional response that we know: anxiety, fear, anger. This dyspnea is going to be associated to a behavioral immediate response, for instance, stopping the effort if it's an effort that triggered dyspnea, or stopping taking drugs if it wasn't efficient. This is going to trigger some distress and anxiety. And at the level of amygdals, we're going to have behavioral D8 response, and this is also going to trigger disability or a decrease in quality of life and depression. I'm going to take the example of DCO for a BPCO patient who's going to have a thoracic distension due to an effort. This is going to make him more thirsty for air because of the excessive level of effort. So is going to stop the effort, go for a bronchial bronchial drug. And we know the deleterious effect this can have, because the BPCO patient cannot go, for instance, to the third floor where his grandchildren live. So we have some patients who don't get out anymore because of their dyspnea. So there are several scales to assess this. There's the one that's traditional that we can use for patients that are in hospital at rest, but you see that this dyspnea is multidimensional, and having a multidimensional approach is going to enable us to have a better, to identify better the therapies. So we have the dyspnea scale, which is multidimensional because it assesses respiratory discomfort with various levels, a little more, not that much, yes, heavily, but there's also the subjective assessment. Margaret Campbell developed this questionnaire that we call ERTO, so which is going to assess, on the one hand, the neurovegetative response linked to dyspnea, cardiac frequency, respiratory frequency, signs of struggle when breathing, the reactions at the end of the breath, but also non-visible language of dyspnea. This score enables us to identify dyspnea for patients who are unconscious, for instance, in palliative care. Once we've assessed this dyspnea, we're going to have to treat it. The prerequisite, it's dealing with the underlying pathology for the clinical cases we saw earlier on. You saw that immunotherapies can relieve you from the impact of dyspnea, but it remains, as you know, it's opioids that can be used. We, as pneumologists, do not fear resorting to morphine. I mean, it's not the same thing as what you have with ambulatory patients for whom you might fear side effects. And then I showed too this this respiratory physiopathology, and we can actually fool the brain either using sensory stimulation or sensory competition, or by manipulating the affective dimension of dyspnea. So now the work of an Australian doctor who fights to have dyspnea systematically treated. He picked 83 patients, 54% BPCO, 29% cancer, and 12% with pulmonary fibrosis, with an analog scale of 14 millimeters at rest. And he assessed the efficiency of side effects of morphines. For dyspnea, the dose of morphine is much less than what you need when dealing with pain. So he first went for 10 milligrams of dyspnea with ongoing release. And after a couple of weeks, if the level of toxicity was high, he was getting out of the trial. Then, if not, he went for phase 4 efficiency study. And if the benefits were insufficient, the dose was increased by 10 milligrams per week up to a maximum dose of 30 milligrams. And as you can see, the doses are extremely low. Then we why did patients get out of the trial? Mainly digestive issues, people vomiting, or neurological issues, people hallucinating, or getting dizziness. No respiratory failure. Only a small percentage didn't respond to morphine, and 50% of them responded to 10, 20, or 30 milligrams. If we look at things more in details, we see that a majority of patients responded to 10 milligrams morphine to deal with dyspnea, which means that even small doses are sufficient, 10 milligrams in the morning, and he didn't give any treatment in the evening, because people don't suffer for dyspnea at night. We here see a significant impact with a change from 50 milligram to 30 milligram. That's moved from dose ranging to longer term treatment. There's also genetic likeliness and check for serotonin, and they saw that one genotype was associated to a lesser extent to response to morphine. So maybe these are the patients who don't have a genotypic modification. What weapons do we have once this morphine based treatment identified? I mean, what I'm showing to you are not treatments for whom efficiency is proven. We can modify the stimulus by fooling the brain. We have here fusimide, furosemide, which is a stimulant. That is, it's stimulating when you breathe in and fill up your lungs, and apnea was prolonged when inhaling furosemide at 40 milligrams before going for an apnea. And the thirst for air, this is actually sorry, here you can see when driven by preventing the patients from hyperventilating under furosemide, the intensity of their air hunger was considerably decreased. We have clinical cases of cancer patients, but no randomized trials, signals that show that furosemide or 40 milligram doses or 80 milligram doses can be efficient with no side effects as it is used through nebulizers. And it shows that the lungs are more filled up. You all chewed eucalyptus chewing gums or menthol chewing gums, and you have the impression that air is fresher in your nose, that your air pathways are freed. It's only sensory, but mental is relieving dyspnea, people suffering from dyspnea, which is why we have non-hypoxemic patients who have their condition improved. We have patients who are under oxygen, they're non-hypoxemic, and they see improvement due to the stimulation of these receptors, which are sensitive to flow and cold, and this gives them the sensory impression that they breathe better. In the United States, we have a palliative care doctor who used in twice blinded, in a trial twice blind, the use of oxygen and of these substances, and we can see an improvement of dyspnea because it's only stimulating these receptors that actually relieved from, the patient from dyspnea. We can also go for cold air. You can use a ventilator close to the face. It's going to stimulate the specific trigeminal nerve, and this is going not only to relieve patients who have dyspnea, but also patients in palliative care who have dyspnea. We see a difference when the ventilator is placed near the face compared to when it's near the leg. And then we have the affective dimension of dyspnea. Either you can have the patient listen to music. This is a treatment that doesn't cost much and doesn't have any side effect whatsoever. Here we have BPCO patients who do a test of a 6-minute walk, and you can see here that if they have music, it relieves their dyspnea and enables them to have a test that's a walking test that's more prolonged. And then if some of you suffer from dyspnea, you can look at this picture. This is hypnosis by working on the brain areas that are involved in dealing with the cognitive aspect of dyspnea. You can relieve dyspnea. It was proven that pediatric patients were relieved this way. And some trials are going to take place very soon, experimental ones, to try and prove the benefits from hypnosis when dealing with dyspnea. To conclude, I'd say that this refractory dyspnea is a ubiquitous suffering. We're all concerned with this. There are multiple therapeutical pathways. But there's also the affective and neurological aspect. We can have a multidisciplinary approach. In the UK, networks were developed with various doctors, physiotherapists, ergotherapists, GPs, and they give a therapeutic program to the patient, same as for pain, depending on the level of dyspnea. They can do what is called getting. They can relieve their dyspnea at home without side effect. They can watch DVDs for relaxation, and they are given poetry. Now, I'd like to mention this quote from David Carroll: "The active identification and management of chronic refractory breathlessness is a human right." Low dose opiates for refractory breathlessness. Thank you for your